Our next speaker is John Quinn, who's the Executive Director of Surgical Affairs for the Royal Australasian College of Surgeons, and he's going to talk to us a bit about the RACS approach to remediation. John.
Thank you, Mr. Chairman. We're changing feet just a little bit to be practical, and I've been asked to tell you what the college does by remediation. I want to talk about our current approach, the reason we do that, the particular difficulties we find in remediating our colleagues, and there's a couple of areas that the college sees that we should expand in this area. The reason we do it is we've talked a lot about self-regulation and maintaining self-regulation in the profession, and if we're going to do that and convince governments and others that we are really a self-regulating profession, we must be able to demonstrate that we're looking after colleagues who are having troubles. We do this also to give advice to APRA and to the Medical Board of Australia. The situation is slightly different in New Zealand because of the Health and Disability Commission, and things are slightly different, but my colleague, the Executive Director of Surgical Affairs in New Zealand, Alan Panting, does this sort of thing as well. We do it to identify individual problems with surgeons and then to remediate them and get them back practicing appropriately, but not as a punishment exercise. Why do we do it? Well, we need to exhibit professionalism. One of our competencies, if we're going to be self-regulating, is to exhibit professionalism, and part of professionalism is looking after our colleagues. So we need to do that, to exhibit collegiality, and we need to recognise that these surgeons individually have put in a large contribution of time and money and effort and emotion and everything else in getting to be a surgeon, and it seems an incredible waste of intelligence and everything else if it's just abandoned when they get into trouble. And similarly, the community has contributed also to their education in large ways, and again, it would be a pity if this was just abandoned. We need also to recognise, and the regulatory authorities will tell us time and again, that most of the problems that doctors and particularly surgeons run into are not related to cutting and stitching. They're not related to the technical competencies. They're more related to the so-called soft competencies of communication, collaboration, dealing with colleagues, bullying, but you need to recognise bullying is not one of the competencies of a surgeon any longer, but quite the reverse. But it's the soft competencies that get people into trouble. The College of Surgeons offers a service for individual review, and we do that to medical boards and others. We do it to hospitals who feel that they're being challenged or that a surgeon working in their place is not performing as well as they think. Mostly that's to protect their backside and to make sure they don't get sued, but no matter what, requests for reviews of individual surgeons' practices come from a different way. And we're prepared to provide a service to do that. It's not a review of the college, but it's a review facilitated by the college, funded and managed by, and the outcomes of it are dealt with by whoever asked for it. But it's particularly important for a couple of reasons. There need to be agreed terms of reference for these reviews. And the terms of reference need to ask specific questions that the hospital or the regulator or whoever it is want answered. And there's quite a skill, I think, in writing these terms of reference, which hospitals don't do very well. They just want Dr. Jones's practice investigated, full stop. Or what part of their practice, over what period. There needs to be a little bit more rigour and focus on it, but it also means that the terms of reference need to be written in a way that if a problem is identified, that the reviewers who've done so will come up with recommendations about how this surgeon's practice can be changed, improved or altered to deal with the things that they've identified. And it also means that the college is able to provide, along with our specialist societies, appropriate reviewers. Some of the reviewers, it was discussed yesterday that medical administrators see physicians all a bit the same, and if somebody's away or sick, you just move this physician to there because they're all a bit the same. And medical boards, with respect, Dr. Flynn, and the investigators that work with you sometimes see surgeons as all the same. And we just want a surgeon. I was asked a question last week, can you provide me with an ENT surgeon? And I said, yes, that's fine, but for what purpose? We just want an ENT surgeon. And I said, well, where's the practice? Is it a city practice, a university-based practice? No, it's a rural practice. So that's fine. what sort of work does this surgeon do? Well, I just want an ENT surgeon. I said, well, do they do ears and noses, or do they do head and neck cancer? Oh, they just do noses. Well, I mean, you need a focused ENT surgeon to do that. Similarly with bariatric surgery, they often ask, I just want a general surgeon. They're all the same, they all know the same sort of stuff. Well, in fact, they don't. Not everybody is doing bariatric surgery, and bariatric surgery is one of the areas, along with spinal surgery, where there's most problems at the moment. And the most available surgeon is not always the best one to do so. The most available surgeon may be a retired general surgeon who's never done the bariatric procedures that they're being asked to review. They might be a retired spinal surgeon who's never put in the cages and never used the things that are used today, but that doesn't stop them giving an opinion, and surgeons always give an authoritative opinion. Also, because surgeons need to be reviewed by peers. From time to time, we get groups of anaesthetists that say, Dr. So-and-so is not able to do this surgery. He or she's not up to the task. Their complications are too high, etc. I'm not going to give anaesthetics for them anymore. And that's happened a few times. And the college has poked its nose in and said, well, just a moment, we need this surgeon to be reviewed by surgeons and not by anaesthetists or administrators. And when that's happened, almost invariably, the surgeon has been found to be okay, and the problem might be with the communication skills of the anaesthetist and not of the surgeon at all. But we need to recognise that the college is not the regulator. And if we find problems, the college cannot limit anything or put regulations around their behaviour. What we find from these reviews is that sometimes the concerns are overrated. And if there's a proper practice review and find that the concerns are not real at all, that this surgeon's practice and outcomes particularly fit in with the peer-reviewed process, well, then we can say authoritatively to the surgeon and whoever asks for it that this surgeon is behaving appropriately in this part of their practice, and you don't need to get concerned. But we also find, as I mentioned before, that the problems might be with communication, with judgment and decision-making, and the so-called soft competencies that we've seen already. It's rarely involved in surgical techniques, but sometimes it is. And if it is, there are ways of dealing with it. The college's attitude and aim is to remediate rather than to punish. And this is often very difficult, particularly when the soft competencies are the problems, because it requires insight. And most of these surgeons who get into trouble don't have insight. It's often why they've got into the problem in the first place. And if you can tell me how to teach somebody about insight, that would be marvellous, because that's often the biggest problem, both in perpetuating the problem and trying to deal with the problem. What can we do? Well, for the soft competencies, we can recommend that they do all sorts of courses, and the courses might be in anger management, which is a real problem, and the communication and anger management and what they do in the operating theatre. And often it's if their skill level is falling a little bit, they compensate by getting angry and blaming everybody else in sight. Some surgeons will happily go along to courses about dealing with difficult colleagues because they think they're going to deal with the colleagues that they deal with, and they don't see themselves as the difficult colleague, but nonetheless they will go along to these courses and they might learn something. Some of them have difficulty with delivering bad news, and believe it or not, in 2014 there are still some surgeons who have problem with this theory of germs causing disease and hand washing being necessary. If the problems are technical, it becomes a little bit more difficult, and it might be just one procedure. And we've heard this morning about audit, and particularly from Barry Bayliss, who eruditely told us about the Australasian vascular audit, which is a very important one, and all vascular surgeons in Australia and New Zealand contribute to that. Its best attributes are that it's not dealing with death like the audits of surgical mortality, but it's dealing with outcomes, and it's dealing with procedures. And the algorithm that he shows is able to pull out people who might be very good at most of the procedures they do, but one or two they're not good at. For instance, they may not be good at carotid artery surgery, whereas once they were, or they may not be good at something else, and Barry gave us those examples. And with data, you can show surgeons that they're not behaving like their peers, their outcomes are much worse than their peers in that particular area, and we might be able to get them to choose a procedure that they will no longer do. But some need reskilling and some need retraining, and they're different attributes. Reskilling is trying to teach somebody a skill that they've never had. And Craig Campbell talked about emergency medicine in 1984. Well, there are lots of surgical procedures that surgeons who graduated in 1984 didn't do either because they were not around. Laparoscopic surgery was very minor in 1984. Endovascular procedures were hardly heard of. So if you've graduated then or before, and haven't had any skill training in endovascular procedures, for instance, you need to be skilled up in that. Or you need retraining, which is dealing with people who've had a skill and have lost it, or lost parts of it. The reskilling or retraining particularly may be necessary because of illness. People might have been away from practice because of a physical illness or a mental illness or drug and alcohol problems. They may be away from practice for family reasons, and particularly women having children in the early part of their practice may well have time off for having children. There are a number of people who've done aid work in developing countries for a number of years and come back to Australia or New Zealand or Canada, I'm sure, wanting to get back into mainstream practice. Well, what they were practicing in a third world country is not what they're going to be practicing in downtown Auckland or Melbourne. And those people have usually got enough insight that they recognise that they're lacking in some skills, and how can we get it? So we're able to help those people. The retraining, reskilling I've mentioned, and retraining are difficult because we need to find a position where they can be retrained. And they really need to have that in what we regard as a training position now, meaning a position where surgical trainees are being trained. So that the people training are actually used to training people and observing and assessing their skills, and similarly in the retraining position. But where do you get those? Do you quarantine a surgical training position from some bright young doctor who's trying to get skills and is wonderful? Do you take away one of those? We already don't have enough training positions in Australia and New Zealand. Should we be taking one of them away for somebody who's had all these skills and abilities and is now not behaving well? That's a problem. Mentoring might be appropriate. We might be able to get, as we've had mentioned, practice visits. The concept that Atul Gawunde's talked about surgical coaching, I think is a wonderful concept, but you've got to get people to be able to do it. And then there are those who say, I'll take the badly performing doctor and he can observe me. Well, some of them observe for 6 months, but they don't actually do anything, and their skills are not changed at all. They've seen Sir do lots of wonderful things and say, ooh, aren't you wonderful, but it hasn't helped the doctor in problem. Assistance at operations, again, doesn't increase your skills and your training. So they're the problems in public hospitals. We're trying to use private hospitals for training, and I think the issue is different, except that there are two different dichotomies here. Some private patients will say, no, I don't really want this poorly performing surgeon to be doing half of my procedure. The other patients say, my surgeon is so important, they send all the difficult doctors to him, so he must be really important, and I'm glad he's here. We've talked about scope of practice, whether there be limited voluntarily or compulsorily, that requires insight, and we've talked about the Australasian Vascular Audit and the other audits. Practice might need to be limited, and sometimes practice needs to be stopped. And for surgeons, particularly those who are past retirement age, but for whatever reason can't afford to retire, have nothing left in their life if they do retire, and all they know about is surging, and they want to keep surging, and it really means that they should stop surging and grow roses or doing something else. They also lack insight, and it's very hard to convince them. So to the regulators, the college would like to say that in the Medical Board of Australia, complaints and whatever are called notifications. And we know that notifications mainly involve proceduralists, whether they be surgeons, obstetricians, dermatologists doing procedures, or doctors doing cosmetic procedures. The college thinks that surgeons need to be more involved in the sifting process of working out what are real complaints, what are vexatious complaints, which ones are terribly bad, and which ones need investigation. So the college and surgeons would like to be involved in that, and it's run differently in different states, despite there being the Medical Board of Australia. The other issue that the College of Surgeons wants to get involved in is something that's become much more apparent quite recently, and the elephant in the room is depression. Beyond Blue is an organisation that Australians will know about, and maybe New Zealanders, but it's a non-for-profit organisation that deals with depression. and broadcasting depression, treating depression, not so much treating by psychiatrists, but the general concept. Last year, 2013, they did a very large survey looking at professionals and particularly doctors and medical students. And the results were so drastic that the Council of the College of Surgeons invited the CEO, who's Kate Carnell, that the Australians may remember was the Chief Minister of the ACT for some time, and she presented the figures to us about surgeons and surgical trainees, which were a real eye-opener to me and I think many of the members of the Council who heard this. We know that depression is common, but it's about 6 times more common in doctors than other professionals. Of the doctors who experience depression, surgeons are at the top of the list. Why that is, not sure. We know that it's underdiagnosed. We know that it's often self-treated. We know that it's associated with increased alcohol use or abuse. Now, whether people get depressed and compensate by taking alcohol or whether they get involved in alcohol and become depressed as a result, I think it's probably that they use alcohol as a prop for their depression. And we know that surgeons don't seek treatment, particularly because of the stigma in the community about depression. And surgeons are supposed to be big, strong men that don't flinch, and even the women are meant to be big, strong men who don't flinch. And there is a stigma in the community about having been diagnosed with depression. And it's also been suggested that because of mandatory reporting, that if there's a mental illness that might affect or does affect patients in practice, that needs to be reported to the Medical Board of Australia and I presume to the Medical Council of New Zealand. And there's a theory that people are not being treated because they don't want to be reported to the Medical Board. I'm sure the Medical Board's attitude is the same as the College of Surgeons. We'd rather treat their depression and get them back working rather than rub them out of practice. But the biggest figure that raised eyebrows in the College of Surgeons was that 21-point-something% of surgeons experienced suicidal ideation in the last 12 months. That's a staggering figure. And if depression is such a big issue for surgeons, then we need to be involved in that because it seems to me that depression and the things that happen from it are surrogates and are flags and whatever, that something's going to happen bad here. They were able with this survey to point out another couple of things, and that women are affected more than men, and there are 3 particular stages in a medical student or young doctor's career where there was most risk of depression, and they were the transitions. They were the transitions from the last year of medical school to graduating and going into practice. They were the situation just before selection into a surgical or a specialist training program, into the surgical one into the surgical training program, which is a stressful period. And the next one is just before they get their fellowship and go into independent practice. And those are the 3 periods that were identified in a young doctor's life where depression was most common. So the college doesn't quite know how to deal with this, but it's a problem of professionalism, it's a problem of practice, and it's a problem that affects us all, and we need to be involved in it. So, Mr. Chairman, we appreciate from the College of Surgeons that this is a big job. The college is no longer avoiding the problem by saying it all belongs to the regulators, they can sort it out, we'll just sit and watch. We don't have all the answers. We'd like to identify poor performers, and we've heard in the last couple of days ways that that's going to be done much more rigorously and in a much more validated fashion. We'd like to remediate those that we identify, mainly for the safety of the patients that we serve and also for the safety of the surgeons. And most of all, we see this as a matter of professionalism. This is one of the things that we as a profession and as a group of surgeons particularly need to do to look after our colleagues, to look after our surgeons and to protect the patients that we serve.